వేయడం మనం వేయలేదు సార్ ఇది.
So it is a earlier 5 years back. It is a compound fracture or a closed fracture.
ఆ హిస్టరీ లేదు సార్ అది.
That is looking like. Is there any periosteal thickening? Is there any periosteal?
Yeah, it is there, sir.
Periosteal irregularity. The bone is smooth or irregular?
Irregular.
So what it indicates?
Some
periosteal branch.
yes sir.
Okay, it may be XYZ. Yes, go ahead, sir. Still go back. Still the cortex is posterior cortex is open.
అవును సార్.
That means what?
Non-union. Non-union. Avascular union. ఏది సార్? vascular non-union.
What is the classification name? Vascular non-union, avascular non-union. Muller's and Weber's classification.
Yes. Muller's and
Belly
Weber's.
classification for infected non-unions. Infected non-union.
Yes.
It could be osteoporosis.
It can be sir. It might be. మనకు 5 years బ్యాక్ తెలియదు కదా సార్ అది. ఇక్కడ చేయలేదంట సార్. ఎస్ సార్. కష్టమైంది సార్, చాలా టైం పట్టింది. ఎస్ సార్.
So if you use the blade in these cases, what happens? Fatigue fracture. What is the cause of fatigue fracture?
Stress.
What is the stress?
Weight.
Muscle power is
More.
than the bone power.
Yes.
Without any trauma also it can break. Called as fatigue fractures.
Yes.
Fatigue fractures are more common in blades. Stress shielding effect.
Yes.
Stress shielding effect will be there below the blade. Stress risers effect will be there at the end of the blade.
Yep.
Or even in nails also.
Yes.
So why the distal ends? Go back. Why the screw has backed out, pulled out or backed out? What is the reason?
No idea. No idea.
No idea. Because of stress, that's what it is.
Stress.
Stress is torque. And torque will occur. So whatever is there, it takes. Beyond that, it comes out.
Yes.
Yes, go ahead, sir.
14-year-old male with 6 weeks old post-op case of closed middle third distal third junction fracture of left humerus with implant in situ
What implant?
TENS nailing sir.
Huh?
TENS.
What is the tense?
Titanium elastic nail.
What is the age of the patient?
15, 14.
14. Yes, sir.
So we have done TENS removal sir.
6 weeks.
సార్ అది బయటికి వచ్చేసినాయి సార్ కింద డిజిటల్గా.
Is the fracture union is consolidated?
No sir, we have applied a cast sir and we.
You have to follow with this.
Yes sir.
Still there is a gap is there.
అవును.
Gap should be reduced.
Yes sir.
Otherwise, humerus is a
Complicated.
gap.
Yes.
So if you treat it nicely, it will treat inmates nicely. Otherwise, there are high chance of delayed union, non-union. Angulation and rotation. What
Yes.
is angulation? What is rotation?
రొటేషన్ కంప్లీట్ డిస్ప్లేస్ అవుతుంది సార్ మొత్తం ఇట్లా. యాంగులేషన్ అంటే క్రూకెడ్ అవుతుంది అంతే కదా సార్.
నేను ఇట్లా మీకు మాస్క్ తీసి మీకు అన్ని క్లాసెస్ చాలా చెప్పాలి. Yes. So, in the humerus or paraphyseal fracture, how much of angulation can be acceptable? How much of angulation can be acceptable? How much of shortening can be acceptable?
Shortening up to 2,
3 centimeters.
yes sir, 3 centimeters.
Angulation,
Angulation I don't know sir.
20 degrees.
Okay.
20 to 30 degrees angulation can be acceptable.
Yes.
Yes, okay. Rotations, rotations also all are important.
Yes. 71-year-old male with closed middle third distal third.
చదువుకోవాలి. చదువుకొని చక్కగా చెప్పాలి.
కరెక్ట్ నేను ఏవైతే చేయాలో అవి అడుగుతారు సార్ మీరు.
అన్ని చదువుకోవాలి. ఏదో దిస్ ఇస్ ద ప్రీ-ఆప్, దిస్ ఇస్ ద పోస్ట్-ఆప్. అయిపోయా. ప్రీ అండ్ పోస్ట్. 21 years old.
Yes.
See, this house is meant for knowledge.
అవును సార్.
House of knowledge. You share the knowledge, you gain the knowledge.
Yes.
You don't share the knowledge, you rely on guys here. 21 years.
71-year-old male with closed middle third distal third junction, both bone fracture of right leg with no DNVD, closed proximal third both bone fracture of left leg with no DNVD.
Both sides.
Yes sir.
One is distal third, one is proximal.
Problem.
Right is distal third.
అవును సార్.
Proximal is left leg.
Left.
Both bones.
Yes.
Both bones are.
Both bones are RTS.
Yes, sir.
We have done close reduction internal fixation with interlocking nail for right tibia and close reduction internal fixation with same ILN, sir, for left tibia.
How many days old post-op?
I think it's like 4 days, 3 days old. 2 days old. 2 days old.
Wound status, everything is good.
Sir.
Wound status is good.
ఇప్పుడు రేపు చెక్ చేస్తాం సార్ ఇంకా
What about the compartmental syndrome?
నథింగ్ సార్ ఏం లేదు సార్
Injury.
ఏం లేదు సార్
What is the mechanism of injury?
హై ఇంటెన్సిటీ ట్రామా ఆర్టీఎస్
RTA. So bus to bus, lorry to
కార్ పెడిస్ట్రియన్స్
car to pedestrian.
Yes.
Is a pedestrian.
పెడిస్ట్రియన్
So how we get a both bones fracture?
రెండు కాళ్ళకు గుద్దేసింది
రెండు కాళ్ళు.
సార్
ఒకటే
ఇలా వెనక నుంచి గుద్దేసింది
వెనకాల, not from front. Shoot.
ఇట్లా సైడ్ వేస్ సార్ అంటే పోస్టీరియర్ లేటల్ అంటారు కదా సార్
Patient అడగాలి ఏది important. Mechanism of injury is very, very important.
ఎస్ సార్
Both bones fracture. Yes. The one of the problem of both bones leg fracture is there is high chances of compartment.
కంపార్ట్మెంట్స్
Can compartmental syndrome can affect the heart?
క్యాన్ కంపార్ట్మెంట్
Compartment syndrome.
ఇట్ మైట్ సార్
Might గా
Can.
less pregnant to more pregnant. అయ్యనే ఉండవు.
ఇట్ క్యాన్
Yes or no?
ఎస్ అయిపోయింది సార్
కానీ classification చాలా ఎక్కువ అండి.
Thank-
గోపినా లేదా?
పోలే సార్ పోవాలి
వెనిస్ వచ్చాలేదా?
వెనీస్ పోలే సార్
ఎక్కడ మొన్న?
మొన్న వియట్నాం పోయినా
వియత్నాం. How is Vietnam now? Indian currency is valued at Vietnam.
Good morning, sir. These are the cases done in Unit 2. 42-year-old male with 12 days old closed middle third fracture of right clavicle. We had an ORI with plating for right clavicle.
Madam, this is contour AO plate or
Contoured.
pre-contoured?
Pre-contoured, yes. Yes.
AO.
Yes. 36-year-old male with closed fracture dislocation of left humerus. These are the CT films. Three-part fracture dislocation. We had an ORI with Philos plating for left humerus.
Can you show me the calculus tool in this? What is important of calculus tool?
Prevents varus collapse.
Very good.
7-year-old male with closed proximal third shaft fracture of left femur. We have done CRF with TENS for left femur.
Very important. Which nail should be passed first? Which nail should be removed next? Amir Mia, which nail should be passed? Medial is first. Another problem. In different lateral should be passed first. Medial should be removed next. అదే చెప్పా చదువురాలు నేను చెప్తే చదివేది. So most of the time the surgeon is standing on the lateral side of the patient. Very easy and so medial side there is a lot of compressive forces. Lateral side ఏంటంటే tension forces. దాన్ని what is the basic principle of plating? To convert tension forces into compressive forces. What is the functions of the nail? To maintain the length, to prevent rotational deformities and for early rehabilitation and for better functional outcome results. We are talking about weight bearing limbs, not weight bearing limbs. Human weight bearing limbs. So how do you calculate when to remove the titanium tens nail, also called as Nancy nail? Titanium nail is also called as Nancy nails. It has got modulus of velocity. Titanium nails will have more of modulus of velocity compared to the stainless steel. Compared to the stainless steel.
Yes.
Is that sir?
Intramedullary nails. Yes.
Stainless steel is Indian made. So I mean,
inside the medullary. What are the 3 points of fixation here?
3 point fixation.
Entry cortex, fracture site, and
Every nail should have 3 points. Every stable line, elastic line should have
3
point
points.
fixation inside the medullary. So one distal, one
Fractures.
middle. That is why you are putting the curve.
Yes.
Either C shape or S shape. If you are putting nails on the same side, from the same side, one One should be C-shaped, one should be S-shaped curve. Otherwise, you won't get the inside 3-point fixation. Is proximal one, in the middle one,
Distal.
distal one. So it is like this. One on the lateral side, one on the middle side, on the distal one will be the lateral side again. Same goes for the other side.
So what is the entry point from the
Yes.
growth plate? Entry point from the growth, what is the distance? 2.5
Should be
centimeter.
2 to 3 centimeters.
at least should be more than
2.5 centimeters. Why? Why it should be away from the growth plate 2.5 centimeters? Away from the growth plate. Why?
Growth plate growth
It can cause growth arrest, or it can cause hyperemia, or hyperemia and increase in growth, decrease in growth. Anything can happen. So that is you should protect the growth plate. And medial side medial side lateral side vascular bodies are coming from the medial side.
Can you insert from the proximal end?
Yeah, proximal to distal. It's a retrograde nailing.
You can insert from there also. This is slightly subcutaneous. Not the much. So you can insert subcutaneous also. Yes, sir. Just to be the
This is retrograde. So the medial one go up to the neck. Medial one will go up to the neck. The lateral one will go up to the
Zit.
So then only you get a good 3-point fixation. Yes. What is the advantage of 3-point fixation? To maintain the length, to maintain the rotational stability. That is the point. Okay, this is the point.
That is
So that we can have the early rehabilitation. When to remove the nail? Is there any calculation in children? 7 years or
6 months.
7 years. When to remove the nail? How do you calculate? So 1 year, 1 week plus 2. 1 year, 1 year, 1 week plus 2. Ante 9 weeks. 9 weeks equal to how much? 2.5, nearly 2.5 months. So do you want to remove 2.5 months? No. So ideally, before 1 year it should be removed. 6 months to
Twelve.
less than 1 year. Why? Why less than 1 year? Why not more than 1 year?
growth.
Yes, it affects the growth disturbances. Growth
That-
disturbances are more with the plate or more with the nail?
Nail.
Huh?
Nails.
Nail. More with the plate. ఎందుకంటే రిజిడ్ ఫిక్సేషన్ అంటే ప్లేట్ అనేది గట్టిగా ఉంటుంది నాట్ విత్ ద నెయిల్ నెయిల్ ఎందుకు లైట్ గ్రోత్ సో సమ్ ఆఫ్ ద టైమ్స్ ఇఫ్ డిలే ద నెయిల్ విల్ బరీ ఇన్ టు ద బోన్ దెన్ ఇట్ ఇస్ వెరీ డిఫికల్ట్ ఆల్ ద పాయింట్స్ ఆర్ వెరీ ఇంపార్టెంట్ సో యూ షుడ్ నో ద indications, contraindication, complication, management of the complication. All should be in toto. Never treat the fracture nor disease. Always treat the patient in toto. Evaro cheppinadi? William Osler. Sir William Osler. Sir, your Sir William ekkada? UK. All yes, sir.
36-year-old male with
Sir William Osler.
Sir, he is the ready.
third 36-year-old male with grade 1 compound middle third shaft fracture of left tibia. We have done CRI with ILN for left tibia.
So both bone fracture, single bone.
Single bones.
So what is the advantage of single bone fracture versus both bone fracture? Which is better? Which is better? This single bone fracture is ideal for operator or not? Operator, yes. Answer is right. Reason? Early mobilization. Orthopedic movement is life. Life is movement. Whose statement is this? Movement is life. Life is movement. Campaign release. Lenin heads for very good. Campaign, champion was there. So much champion around the campaign. Champion release. An English novel. I am Indian. I cannot pronounce it. I think Imanov can pronounce very nicely. Or our other Mia will pronounce it. Good, yeah? Fluency is also. Champion release.
48-year-old female with closed lateral malleolar fracture of left angle. We have done OR, sir.
Show me the fracture. The pointer cursor. infrasyndesmotic or suprasyndesmotic.
What is rubber type, what is large Hansen?
Sir, only lateral malleoli we can't say Lag-Hansen type. Isolated lateral malleoli.
Sir, as for the Dennis Weber classification, whether it's of transsyndesmotic syndesmosis will be affected. So syndesmosis is very important to bind the ankle mortise. Yes. So that is the reason why mortise you. Why for mortise you? Mortise you
Syndesmotic injury.
integrity of the syndesmosis.
Syndesmosis.
Yes, sir. Indication for surgery.
Sir, weight bearing syndesmotic injury. No, sir. No, sir. We can also treat conservatively also, sir.
How conservative syndesmosis involved? When syndesmosis, how do you treat conservative? How much time it takes?
Nearly 8 weeks it takes.
Any ankle injury, how many weeks time it treat? How many weeks time to treat conservatively?
8 weeks.
8 weeks, 8 to 12 weeks. 3 months में wait चल. और आपको 3 months में wait चल. पहले पंद्रह. So did you attend syndesmosis?
No, sir. I was not there.
Poroperative finding. What is poroperative finding to know there is a syndesmotic involvement? Squeeze test. You have to go 7 to 8 centimeter above the syndesmotic. Just to squeeze it. Squeeze test not open it. Syndesmosis.
Intraoperative, how to check syndesmotic instability?
Squeeze test. Intraoperative.
With a hook and
Lavata sheet.
hook case local. Local.
Arogis.
So you are not fixed the syndesmotic screw. There is no syndesmotic screw.
No, sir. No, sir.
Means what? There is no syndesmotic screw means what?
Minimal damage to
So
syndesmosis.
there is no syndesmotic injury. So there is no disruption of the syndesmosis. Syndesmosis can be partially disrupted or it can be completely disrupted. Where do you get partial disruption of the syndesmosis? Where do you get complete disruption of the syndesmosis?
When you told large Hansen classification,
Let me answer.
Lag-Hansen class.
really, like it.
Sir, only isolated ki medial malleolar involvement ఉంటేనే Lag-Hansen classification we can differentiate. Sir. Ligaments also.
It is like a circle. Always something has to break on the other side or tear on the other side. So you cannot break single bone here. There has to be some medial injury. Either partial strain or complete strain of the complete tear of the deltoid.
Deltoid.
There has to be.
53 are male.
On what basis they have classified the Lag-Hansen classification? Basis for every classification. There is something called basis.
Yes, sir.
What is the basis for Lag-Hansen classification?
Foot position and direction of injury, force of injury. Sir.
Okay. It is a clinical radiological it is a clinical radiological cadaveric experimental based study. That is Lag-Hansen classification. And actually there is what is called one person, Sir Percival Part. He also talks about bimalar fracture. But he unable to describe the mechanism of injury of ankle. So it was nullified. They never accept the bimalar fracture mechanism. So that's why Lag-Hansen classification is more commonly called as a generic classification. What do you mean by generic classification? Sarvasadaran, commonly used. Sarvasadaran. Uppulo పోయినాడు నలుగుతున్నారని అందరూ accept చేస్తారు కాబట్టి they use the Lag-Hansen class because it is based on clinical, radiological and cadaveric experimental studies. It is an evidence-based classification. ಸುಮ್ಮನೆ ಸುಳ್ಳು ಬೇಡ ಸೂತ್ರ ಬೇಡ ಮನಸ್ಸಲ್ಲ
రాదు సార్ నాకు
మనసులో ఏమంటే అర్థమైతే లేదని అర్థమైంది.
అర్థం.
నేర్చుకోవాలా
53-year-old male with closed middle third distal third junction shaft fracture of right femur with bimalleolar fracture of left ankle and Lisfrank's injury of left foot. Sir, it's supination external rotation type of Laganson classification and Meyerson type B2, sir. We have done CRAF with ILN for right femur and ORF with plating for lateral malleoli and malleolar screw for medial malleolus for left ankle and CRAF with K-wire fixation for second, third metatarsals of left foot. Sir, it's contralateral, sir. Contralateral injury. Femur right side, sir. Left femur right, ankle left side. Sir. Second, third, and fourth metatarsals and fifth metatarsal side kelpina, sir. Lat.
So what is the other classification for Lisfrank injuries?
ఇది మేయర్సన్ సార్.
No classification? To knee and push.
అబ్డక్షన్ టైప్ సార్. అబ్డక్షన్. Yes, sir.
What is the fracture line in the medial malleolus? A vertical or oblique or
Oblique
nearly
type of-
vertical fracture in the medial malleolus and a horizontal fracture at the level of the joint in the lateral malleolus is an adduction violence. This is a pull-off fracture. This is a pull-off fracture. This is a push-off fracture. Push-off.
Push up.
Push-off is vertical. Pull-off is avulsion-like fracture. So this will be at the level of the joint line. This is where the place of displacement starts. This is the first event. This is the second event. Okay, is there any incongruity? Is there any posterior subluxation?
No,
Is there a posterior malleolar fracture?
No, sir.
There is no posterior malleolar fracture. It is a true abduction adduction violence. In the opposite variety, that is the abduction violence, the medial malleolar fracture will be transverse at the level of the joint. That is the first one to fail. And when it fails, it may stop at that level. Or if the violence continues, if talus continues to rotate in the ankle mortis, then there will be a fracture fibula in the oblique fashion above the level of the joint with comminution of the lateral cortex. Okay, that is the typical adduction and abduction. So, looking at the morphology, you can say it is a abduction violence or an adduction violence. Okay.
What do you call this type of fractures? So right side is femur, left side is ankle and foot. What do you call this type of fractures? Is it arteria or
RTA.
arteria was postversal was lari?
Bike versus tractor.
Open injuries or closed?
No, sir. Closed.
No commas.
No comments.
Here it appears an anatomic reduction. Go back. The direction of the force of the screw when it is trying to fix it, there will be a shearing force here. In order to counteract the shearing force when the screw is being introduced, you have to put a horizontal screw perpendicular to the fracture line. Here it is almost oblong, the screw. That is true with an abduction fracture, which is a transverse medial malleolar fracture. The first screw should be here to counteract the shearing force of the screw. Yes, next. See this. It appears okay, but ideally, as for principle, first screw should be in this direction. You see what is the angle between the screw and the fracture line? Very acute.
Yes, sir.
Okay.
75-year-old.
Disc strike injury is usually there is separation between first metatarsal and second metatarsal
Second.
base.
Yes, sir.
First
Tarso
base is
metatarsal.
intact. Base is still aligned to the
First.
tarsal.
Yes.
It cannot be called disc strike actually.
What is wristband fracture dislocation?
The purely base fractures.
Tarsometatarsal injury. Metatarsal
Fracture or fracture dislocation?
fracture dislocation.
Wristbands or fracture
Fracture dislocations.
Here, as you said, the basis appears to be intact with the cuneiforms. Okay, it is only displaced base fractures.
What about the base of the fifth metatarsal? Is there any injury? No injury?
No in
Looks like a smooth line.
No
or
in
it's a step.
step.
There is some
We can see steps.
gap in the
Late.
base of the fifth metatarsal.
Late.
There are two rounds.
It appears intact. Next, go ahead.
75-year-old female with intertrochanteric fracture of left femur. Boyden Griffith type 2. We have done CRAF with long PFN for left femur. 23-year-old male with grade 1 distal third shaft fracture of left humerus with no DNVD. We have done ORF with plating for left humerus. Sorry, contour plating. 29-year-old male with closed distal third shaft fracture of left ulna. We have done ORF with plating for left ulna. Yes, sir. It is treated as intraarticular. Generally, both bones are treated as intraarticular.
Universal phenomena of intraarticular fracture. Not all fractures require fixation. It is a waste of surgery. It is in good alignment, no overriding, with stable fracture. Even a below elbow herniantoplasty will be able to take care of this immobilization for 6 weeks. At the same time, you can move the elbow right from day one. It is just like a very close to the nearly the solid fracture, maybe a little higher level. There is no indication at all for surgery in this case. It is a nightstick fracture.
Yes, sir. Nightstick fracture.
Assaulted.
Yes, sir. Assaulted.
Until proved otherwise, a single bone ulnar fracture, especially in the middle and the distal third, they are almost always assault. Even if the patient doesn't do the proper history, it should be considered an assault.
What type of plate is that?
Sir.
What type of plate is that?
Semitubular.
Huh?
Semitubular.
Semitubular.
Recon plate.
It is a recon.
Recon plate.
You are locking recon. What is the thickness?
Say recon.
3.5 or 2.7?
2.7.
2.7. 3.5 అది. ఏమన్నా? 3.5.
2.7.
సార్ చదువుకురాడు ఏదో మంత్రాలు తెలిపితే లాభం లేదు.
What is this screw?
Sir.
Regular
locking screw.
Yeah, you can't see the screw
We
from
can't
here. It is buried into the plate. How do you say it is a locking edge screw?
we can't see the head.
Huh?
We can't see the head
Can't see?
heads of the.
Head will not be same. Head will be sinking even in the DCP also. The pitch of the screw. Pitch of the screw. You know what is pitch of the screw?
No,
Huh?
don't know.
No idea.
No,
So have you fixed any fracture with your hand still now?
no,
You have not fixed any fracture. The distance between the two adjacent threads of the screw is called the pitch. The pitch is very, very small in the locking edge screws. It is wider in the article screws. And the tip of the screw also is almost like a pointed one, like a proper tip.
Rooted tip of it. You have
Pitch
self-tapping,
and tele-
you have
tele-
self-tapping
tele-
and non-self-tapping.
Next. Nobody is reading about the instrument.
Here also X-ray
Instrument
we have to
chapter
post
in
off.
Campbell.
చదువుకొని రావాలి.
Next.
65-year-old male with intercapsular fracture of right femur.
How many days old?
Fresh, sir. Fresh fracture, sir. 1 day.
One day old. Stress fracture.
Fresh
Stress
fracture.
fracture. So what is the mechanism of injury?
Trivial fall.
You have at home. At first hand or
At home.
At home. Okay. What is the Gordon's classification?
Mechanism of injury is different. Nature of violence is different. Nature of violence is trivial fall. Mechanism of injury is a direct injury and a rotational injury. Is it rotational or direct?
It's direct injury.
Direct.
They told that it's.
What is
But
Almost all the intracapsular fracture neck femurs are
rotational injury.
rotational.
Rotational injuries.
They are indirect injuries.
This fracture is not true transverse. You see the peak of the head and the proximal part of the fracture line is almost just at the junction of the head and the neck. This will have a beak here. It is not true transverse fracture. Though in the X-ray it appears that it is a transverse fracture, but almost always they are all spiral fractures. See, you can see a beak here now.
Yes.
Okay.
We have done hemiarthroplasty, bipolar cemented hemiarthroplasty for right hip. 35-year-old male with intracapsular fracture of left femur. We have done CC screw fixation, which is known as BDSF technique. Biplanar double support screw fixation.
Double support.
Screw fixation.
Then it will called as F technique. What is F technique? This is also F technique. Another pair F technique.
Okay, how do you rate the reduction? Reduction is the key to the success in all intracapsular fracture osteosynthesis. Reduction is the key to the success of union. What is the quality of the reduction? How do you judge the quality of the reduction? Green BDSF, fine. Supposed to be mechanically stable than parallel CC screws. Yes, anybody? How do you judge the quality of the reduction of the fracture? తెలీదని చెప్పాలి అలాగా నిలబడకూడదు. Anybody from behind? తెలిసినా కూడా చెప్పకపోతే అది పర్మనెంట్గా మర్చిపోతారు. ఒక శాపం.
If you share the knowledge, you gain the knowledge. If you don't share the knowledge, you lose the knowledge. Become a
See, there are what are called as the Lowell's S-shaped lines. Lowell's, okay, that is first criteria. It should be studied both in ATV as well as lateral view. there laterally here?
No, no, sir.
Generally we don't take. But you should have taken it on the table and the Siam.
Yes.
Siam, do you have Siam pictures?
Only APV.
So here S shape means put the post-op Excel. Here you see in the normal, this is the reverse S. Okay? S shape, smooth line. Here S shape. This is S. Starting from the head to the neck to the trochanter. Which is resembling like an S. Here is a little longer S. This is reverse S. Okay? S shape and reverse S shape in AP. Here it is almost straight, you see, the head and the neck up to the lesser trochanter. And there is impaction, of course, impaction is a good thing, but it has lost the so-called smooth S shape curve. Here there is an acute kink in the S shape. No? There is a kink here. It is opened up here. Of course, probably this might have been a little combination might have been. Okay? So this is not a good reduction. Okay, another thing is Gordon's alignment index. You can see that there is compression vertically here. Gordon's alignment index. So the lower S-shaped lines, they are not accurate, and the Gordon's alignment index, you see the angle it should be 180 plus or minus 4. Weight is 180. It should correspond with the particular pattern of the iliac. That is the line of weight bearing. See here, this is the line. It should have gone like this. Here, this particularly in the head, they are valgus. The valgus head is more likely to produce radiant changes. Valgus.
The fresh one, this is
Yes, sir.
35.
close reduction or open reduction?
Open we have. First we tried close, sir.
Not able to.
Yes, sir.
The open reduction,
Yes, sir. Open. Open
you
reduction.
open the capsule and see the fracture.
No, not at the capsule, sir. Only.
What do you mean by open
Venkala.
reduction? When you open the capsule and look into the fracture, that is called open reduction.
Yes, sir.
Not it's a closed reduction. And internal fixation.
Sir. No, sir. By leg butter technique we can leg butter. Sir. Left. Left, sir. CMV only peaks. Left, sir. Reduction peaks.
It's not openly reduced.
No, sir.
Who did it?
Jairam, sir. Jairam, sir.
So close reduction only.
Yes, sir.
Lateral view looks okay, but this is valgus. I think it's not valgus impaction fractures will be better prognosis, but valgus it's not impacted. Valgus position, I think, with too much of valgus. Though the sharing forces are less in valgus position, but I think might. Bad. Yes, you're right. Might get away. Okay. So post-op, what do you do? How do you mobilize or how do you manage rehabilitation?
Sir, we advise non-weight bearing for 6 weeks until the soft callus form.
6 weeks soft callus will form. What is soft callus, hard callus?
Soft callus is an woven bone, sir. It's laminar.
You can't make out soft or hard. So 6 weeks is minimum
Yes, sir.
and might take up to 3 months, maybe 6 months.
What is intracapsular fracture? What type of union is intracapsular fracture in a femur?
It doesn't form callus.
Creeping substitution. This is a union. There is a method of union in intracapsular fracture in a femur.
So very difficult to assess the fracture united or not. So we should do minimum 3 months maybe non-weight bearing. Then we have to assess, maybe get a CT scan at this level, because there is no callus formation here. So difficult to assess whether fracture united or not. Okay.
So plate and screw fixation is a better construct at the level of intracapsular fracture. Why? Why instead of screws? Advantage, disadvantage. Plate and screw construct is better than the screws. Why?
Compressive support.
The level of hip joint, the shearing forces are getting converted into compressive forces. There is lot of joint reaction forces. Otherwise, it never becomes like a biomechanically stable construct. That is called FNS, femoral neck system.
Yeah, nowadays I think probably preferable to do 2-plate. The special plates have come with the 2-hole onto the fixation onto the shaft will what is that reduces the shearing forces. You are right. Okay. Yeah, FNS. Yeah. Okay, gone.
70-year-old female with grade 2 bimalleolar fracture of right angle. It is supination adduction type. See, abduction type. Abduction.
Mm.
Fresh fracture. Abduction.
What was the abduction? How it looks?
Just now I explained, no,
sir.
fracture morphology.
Fracture fragment, medial malleoli is transversely fractured.
Medial malleolus transverse fracture
and
at the level of the joint
at the level
line,
of joint.
and lateral malleolus above the level of the joint
Oblique type.
with an oblique
fracture.
comminution of the lateral cortex.
Yes.
That is a typical abduction violence.
Abduction.
It is a reverse. Go back to the first X-ray. In contrast to this, you see, this is a transverse fracture at the level of the joint in the lateral malleolus and a vertical fracture in the medial malleolus. This is a typical adduction.
It is.
You have got 2 examples of typical abduction and adduction. Next.
We have done CRIF with rush nail for lateral malleoli and tension band wiring for medial malleolus.
Malleoli is not singular. 2 malleoli or 3 malleoli, then you call it as malleoli.
Yes, sir.
Next.
78-year-old female with right intertrochanteric fracture with closed right distal end radius fracture with 6 years old IC fracture with implant in situ.
Which one is more painful for her? Right hip, left hip, or the wrist
Sir, right hip.
is more painful?
Yes, sir.
Left hip?
Left hip she is not complaining of.
What's left hip? Can you see the X-ray? Describe the X-ray left hip.
It's an 6-year-old IC fracture.
6 years. Is it written there? 6 years?
No, sir.
What is there an X-ray?
Sir, in the right hip we see the intertrochanteric fracture, and for left hip they have done hemiarthroplasty with AMB.
No, describe the X-ray of the left hip. There is osteomorphosis there. What else is there? See, look at the hip joint. What happened to the hip joint? Anybody? Anybody won't answer. Anybody is nobody, is it?
Acetabulum. Acetabulum, there is no acetabulum.
Yeah. What happened to acetabulum?
Protrusion of protrusion.
Eroded. Not gone to protrusio, eroded. There is no joint space.
Yes, sir.
So what does it mean? There is no joint space means what does it mean?
Arthritic cartilage is
Cartilage is eroded.
eroded.
Cartilage is damaged. And this one, The stem, how it looks?
It's impacting to the lateral cortex.
Ah. Is that varus position or valgus position?
Varus position.
Which is not good, varus or valgus?
Varus is
Not good or good?
not good, sir. Not good.
So varus probably it's loose. Okay. So what was done for the right hip? PFN.
Long PFN. CRF with long PFN for right femur and CRF closed reduction internal fixation with K-wire fixation for right radius.
Okay. Next one.
32-year-old male with closed proximal both bone fracture of right leg. We have done ORF with plating for right tibia.
Okay. Next one. General club. Okay.
Good morning, sir.
Take the mask off.
A novel approach to distal femur, a minimal invasive technique for supracondylar and intracondylar fracture. This journal is Journal of Orthopedic Surgery and Research, Taiwan, sir. Introduction. Locking compression plate fixation is the current preferred treatment for patients with distal femur fracture. It has the advantage of
Go back to the abstract. Did you put the abstract? Yeah.
Yes, sir.
Read this.
For treating distal background for treating distal femur fractures, minimal invasive plating techniques with indirect reduction of the metaphysis while minimizing the damage to the peripheral soft tissue has gradually become the standard. However, all the current approaches use a straight or lazy curved incision adjacent to the patella or along the lateral side of the femur, which allows for easier proximal extension but increases the incision length. And methods in order to achieve a more physiological and aesthetic outcome while leaving the metaphysis untouched, we developed an approach using a lambda-shaped incision, which sacrifices the potential for proximal extension but preserves much more peripheral soft tissue. Here we describe our technique and our experience with 19 patients, 12 men and 12 women, sir. And the results, fracture healing by first intention was observed in all patients. The postoperative knee range of motion can be reached up to 90 degrees in most of the patients. And clinically, 9 patients have excellent results, 6 have good results and 3 have fair results. And 2, there is no follow-up for 2. Conclusion.
Is 90 degrees flexion a very good result?
120 is very good.
Most of the patients up to 90. That means other patients not even 90.
Yes. Conclusion, our minimally invasive lambda incision approach allows sufficient visual access to almost the entire joint surface, including the entire lateral femoral condyle, trochlear surface and distal medial condyle. Where reduction is required, the lambda incision provides a much larger window than that offered by the same length straight incision. The vertical turn at the mid-patellar level parallels the skin crease and geniculate artery, reducing soft tissue damage and resulting in a smooth healing wound. Moreover, plate and distal screw insertion is easier than the straight incision because the metaphysis region is mostly left untouched. Ideal fracture healing environment is preserved. Yes.
No point in introduction also.
Okay. Sir.
What they have done.
So-
Written entire theory.
Yes. Sir?
Written entire theory what they've said.
Yes.
Gone. So what did they do?
They made a lambda incision, sir, which sacrifices the potential proximal extension, but it preserves the soft tissue, sir.
What about inclusion criteria?
Inclusion closed distal femur fractures, closed supracondylar fractures, and closed intracondylar fractures inclusion criteria. Sir? No combinations.
Combination included or not included?
No, so only till 33B1 it is included. AO. And exclusion criteria, open fractures and revision surgeries, and pure medial condyle fractures and Hoffa fractures, a coronal. Surgical technique. The patient is placed in a supine position. A triangular leg roll is positioned beneath the knee to maintain a flexion of approximately 45 degrees. A tourniquet is not used because it may compress and anchor the quadriceps muscle. The incision starts from Gerdy tubercle and extends proximally parallel to the patellar tendon. A perpendicular turn is made after reaching the mid-patellar level and is extended towards the lateral femoral epicondyle along the skin crease of the knee, forming a lambda-shaped incision, as we can see in this image. The retinaculum is then incised in the same manner as a skin flap. A curved Hohmann retractor placed across the suprapatellar pouch to render visibility of the intercondylar notch and joint congruity. After intracondylar fracture reduction, Kirschner wire or K-wire or periarticular reduction clamps can be used to fix the distal fragment. This is followed by minimally invasive plate osteosynthesis procedure. This image shows LIS method, sir. The proximal screws are applied through approximately 1 centimeter puncture windows under the guidance of intraoperative radiography. Complex intercondylar fractures or fracture fragments at the far medial side of the femur, a small medial window of approximately 3 centimeters can be made above the medial epicondyle. Both the retinaculum and iliotibial band are closed and repaired with an absorbable suture. Sir? We cannot. Trochlear surface we cannot access.
So everything is done close reduction.
Close reduction, yes, sir.
You can't see no direct vision.
Results: 12 men and 7 women. Mean age is 52 years, sir, and range 20 to 81. All patients were treated with single lateral plating of the distal femur. Iliotibial band release was done in 7 cases. The mean operation time was 192 minutes. It is from 90 to 420 minutes, sir. All surgical wounds healed by first intention and no implant failure occurred in any patient.
92 minimum 3 hours?
3 hours.
More than 3 hours?
Yes.
Okay, probably they can do only 1 or 2 cases in a day.
Yes.
I'll go back. X-ray, show the X-ray. And again, you see this. Medial side, there is no support, it's going to collapse. Unless you put a small plate on that side.
Background, yes. Dual plating.
And here also, you can see. There is split here or no? And then this piece is entered, piece is free. No contact. Did you discuss with anybody in this article?
Yes, sir. Ali sir and Sridhar sir, I sent the article, sir. Radiographic signs of bone union were reached at a mean 13.7 months, which is like varied from 7 to 22 months. Only one patient reached full union within 9 months. One patient sustained malunion with a genu-varus deformity and a post-operative joint range of motion. 8 for flexion greater than 120 degrees and 8 is for 90 to 120 degrees of flexion. And 2 is if the flexion is less than 90 degrees. And clinically 9 means excellent results, 6 is good result, fair is 3 and if there is no follow-up it is 2. The classical lateral approach described by Marcy remains popular for treating supracondylar fractures. Lateral approach can only provide limited access to the intracondylar notch unless the wound is extended and dissected thoroughly to subluxate the whole extensor component medially. The modified J-shaped or hockey stick incision is less commonly used because it causes extensive soft tissue destruction, and mini swashbuckler approach has been considered an ideal technique for treating distal femur fractures.
What is swashbuckler approach?
Mini swashbuckler is a midline incision, sir. Mini swashbuckler is from tibial, lateral tibial notch to the patella tendon work, sir. It's curved towards the lateral sides. Image better less. Sir? Swashbuckling. It flap laga this. It's a name, sir. Technique. Okay, sir.
See, if it is a name,
Yes.
look at it.
Yes.
If it is a name, the S will be capital.
Yes, sir.
Common sense.
Yes.
And you have to little diagram here. Put a lot of theory. Okay, go on.
Mini Schwarzbachler approach is 12 centimeters and lambda incision is 9 centimeters. The current concept in treating distal femur fractures is to reduce only the articular surface, leaving the metadiaphysis portion untouched. A lambda-shaped incision sacrifices the potential for proximal extension and preserves much more peripheral soft tissue. The corner flap formed by lambda incision can be turned down, creating a much larger window than that offered by a same length straight line incision. The vertical turn at the mid-patellar level parallels the skin crease and geniculate artery, further reducing the damage to the surrounding soft tissue and resulting in smooth healing wound and highly satisfactory cosmetic outcome. When the posterior condyle or posterior cortex needs to be inspected, extending the vertical incision more laterally and releasing the upper part of the iliotibial band via lazy L-shaped incision can easily expose this area with lower iliotibial band intact. A simple approximation can be achieved without excessive tension, no poor healing of ligament and any lateral side laxity issues. Limitation strict vertical turn location is made to form a flap, makes the joint easily accessible, but it also makes the operative field difficult to extend proximally. And the surgeon must be used to operating through a mobile window to reduce fractures. Conclusion: the minimal invasive lambda incision approach allows sufficient visual access to almost the entire joint surface, including the entire lateral femoral condyle, trochlear surface, and distal medial condyle, where reduction is required when performing minimally invasive plate osteosynthesis. Advantages: the least metadiaphyseal soft tissue damage, preserve all anastomosis ring well, exposure of the implant position site, posterior femoral cortex reachable, and the best cosmetic appearance. Disadvantages: long learning curve and more surgical time, difficult to extend the wound if clinically required. Whichever approach a surgeon is more efficient and more confident with will be the safest approach in the surgeon's hands.
That's a good message.
Sir? Laxative ఉంటుంది joint. What's that? Strength. It will be decreased. It will be decreased.
What is the function of IT band? Sorry,
It maintains tension, sir, of the joint.
okay. Your criticism?
Criticism: study design flaws. The study is a case series of only 19 patients with no control group. Randomization or prospective comparison making it impossible to conclude the new approach is superior to existing methods. And small sample size with only 19 patients and 2 of them were lost to follow-up. The study lacks the statistical power to draw significant conclusions. Limited outcome assessment. The evaluation of outcome is incomplete, relying on limited measures, range of motion and Sanders scores, and lacking validated patient reported outcome measures like KUS and SF36 and long-term data post-traumatic arthritis, return to work. Inadequate follow-up. The follow-up duration is insufficient to long-term complications such as malalignment, implant failure, or the need for secondary procedures. And significant selection bias. The study's exclusion of complex cases Example, open fractures, Hoffa fracture, create a highly selected patient population with artificially inflates results and limits the generalizability of the findings. Learning curve issues. The authors acknowledge a long initial learning curve. Emphasis on comesis. The paper prioritizes cosmetic outcomes over more critical factors in high energy fractures, such as functionality and union rates. Lack of direct comparison. The discussions claim of improved exposure and easier implant placement are subjective and not supported by direct head-to-head comparative data. Conclusions. The study's evidence is weak because of its sample size and lack of control group. It serves a good technical introduction to a new surgical approach but does not provide enough proof to recommend it over existing techniques. While the lambda incision shows promise for minimizing soft tissue damage, stronger evidence from larger or more rigorous studies is needed before it can be considered a superior option. Thanks.
Did you write a criticism or?
I put it in ChatGPT. ChatGPT.
It is very obvious. Looking at the terminology, in the criticism, it is very obvious. Even if he says
Put the entire article on this one and
ChatGPT.
I think that's a good one. Very good criticism. And last night there was a program on what is that? NDTV. On what is the discussion part, they are putting everything into ChatGPT and reading it out. So it's become very common that it's become a very powerful tool nowadays.
Thank you, sir.
Yeah. Right. Relevant. Uh-huh. So medically, probably it's not very scientifically, I don't think, but it gives very good formatting. Language, it improves your language. Language, it will improve, but I don't think polished. Some you want to create some greetings or general things, not scientific things, messages, letter. Yes, they will. Done. Okay.
What way this chart GPT differ from AI? అంతేంటారా అంతే
ChatGPT is the AI bot for OpenAI. Again, we have localization, we have Gemini. It has business by Google,
It is from US based or UK based? US based.